Dr. Ouyang. It's a real pleasure to have you today on JACC Asia Pulse as part of our Peer Perspective series on AI in cardiology. I'm Hyun Jin, and I'm excited to hear your experiences and perspectives today.
Yes, hello, Dr. Ouyang. I'm Jeehoon, and it's an honor to meet you. And I hope that our conversation today will be very informative and inspiring for our audience. To begin, could you please briefly introduce yourself to our viewers?
Yeah, Dr. Ahn and Dr. Kang, first, thank you so much for having me on your program. I'm very excited to be here today. My name is David Ouyang. I'm a cardiologist as well as a echocardiographer at Kaiser Permanente in Northern California in the United States. I grew up in Texas and was in California for medical school, residency, and fellowship. And I was at Cedars-Sinai for about 4 years and recently joined the faculty at Kaiser Permanente. I do clinical work in the Echo lab as well as through Cardiology Consult. I have a NIH-funded research lab where we focus on AI and cardiology, and very excited to do both deployment and development of AI technologies. I also serve as a deputy editor for NEJM AI.
Yes, I see that you are very actively conducting research on AI in cardiology and serving as a deputy editor at NEJM AI. May I ask what first inspired you to explore AI in cardiology, and how has that motivation shaped your research journey?
Yeah, I think nowadays it feels like AI is part of every conversation or every research topic, but this was something I was interested in even 10 or 15 years ago. My background is in statistics, where I had a statistics degree at Rice University, and during medical school did a lot of programming as well as statistical analysis of large cohorts. When I was doing fellowship at Stanford for cardiology, we are fortunate to have a very large computer science department that's across the street. So I did a 2-year postdoctoral fellowship in Dr. James Zhao's lab, where this is what started my interest in deep learning and the integration of AI in cardiology. There's so much great data in cardiology that's not being used, and really that's an opportunity to develop AI algorithms.
Okay, so as far as I know, you recently led one of the randomized clinical trials testing AI in cardiovascular care. Actually, the traditional randomized clinical trials are comparing two different clinical strategies, which is not that much related in AI. So could you briefly explain the aim of the trial and how you applied AI to this trial?
Yeah, so I would say right now it feels like for every 100 AI papers that are published, maybe only 1 or 2 AI technologies are actually deployed in clinic. We developed an AI algorithm that on the echoes has a precise assessment of ejection fraction, but this was something that we saw even with many commercial clearances, very few people were using this in clinical practice. So our clinical trial was actually embedding our AI system into the PACS system, or the software that's used to look at echocardiograms, and randomizing cardiologists to whether they see a preliminary assessment by AI or a preliminary assessment by sonographers. We thought that it was important to blind and randomize cardiologists in this kind of format, because as you guys all know, randomization and blinding are pillars of understanding the true effect size of clinical interventions, because there might be opportunities for bias or essentially different ways to interpret the results. We found that cardiologists were less likely to adjust the measurement of our AI LVEF compared to the preliminary assessment of the sonographer LVEF. And we thought this was an opportunity to show that there is both improved precision as well as decreased time and improved efficiency in both the sonographer and cardiologist workflow.
Okay, so you just explained how this trial was different from traditional RCTs. You said that the trial was based on a LVEF measured by AI. Is that right?
That's right. So to the cardiologist, they saw a traced LVEF that someone did before them, but we did not show them whether it was done by AI or sonographer.
Okay.
Beyond clinical trials, I can see that echocardiography has also been a major focus of your work. Could you share how AI is currently being applied in echocardiography and where you see its greatest potential?
Yeah, at a high level, I think that AI has great potential to do 2 major things. One is, are there human tasks that are potentially tedious or imprecise or invariant? or are there tasks that humans cannot do? The LVF example is obviously a task that clinicians do day in, day out, but potentially with AI being software can be a little bit more precise and a little bit more reproducible. The second piece is, are there tasks that humans cannot do? And our lab's been fortunate in developing algorithms in that vein as well. So we develop algorithms for the detection of cardiac amyloidosis, as well as the detection of liver disease on echo. I think that people are often surprised that we're doing liver disease on echo because echo is cardiac ultrasound. But the general idea I think of is, as a cardiologist, I'm never trained how to interpret the echo to look at liver disease, even though we have images of the liver when we look at the IVC. So that if there's a diagnostic aid like AI, potentially that's a way to identify cirrhosis and fatty liver, even in the images that we already obtain, so that the imaging that we're getting obtained already has increased and better clinical value.
It's very interesting. Based on your trial and ongoing work, how close do you think we are to seeing AI tools truly integrated into routine patient care, and what barriers still need to be addressed?
Yeah, I think it's an exciting area, and there's still a lot of work to be done both by clinicians as well as non-clinicians in actually integrating into the clinical workflow. I think that vendors and the industry has been very thoughtful in integrating technology into the devices and the computers that we currently use. I think it's very important to integrate them into our current clinical workflow as opposed to trying to get people to buy an extra computer or go to a website. And I think that the main challenge right now is how to work with clinicians efficiently and effectively, so that how do we actually present the data in a way that humans can understand, that clinicians are still in control and can override, and as well as in many parts of the world, a question of what does it mean for reimbursement? Like how do one pay for AI? What happens when AI potentially makes a mistake? And how do we think about the legal as well as the social implications of using it in healthcare?
Well, just one question about the liver issue that you mentioned. Regarding echocardiography, because we're going to have a lot of echocardiography education videos in our JACC Age of Pulse. One of the most important things in echocardiography that is different from CT and MRIs is that it's basically most on how you get the image by the sonographer or the primary physician. So the location of the probe, how you make the patient, the respiration control, and the body size of the patient. So how do you deal with these kinds of errors that's not related to the images that we see in the radiology department?
Yeah, no, that's a really great question. There's both a lot of opportunities with ultrasound as well as a lot of challenges, as you've described many of them in ultrasound. What I would describe, and a big focus of our lab, is the aggregation of large data sets. In the same way, when you think about ChatGPT or Gemini, they're trained on the internet's worth of data. And the internet is very unclean and messy and also very heterogeneous. We found in both general AI as well as in medical AI is that if you amass a large enough data set, enough information where you can see from many different angles and many different image qualities, that AI performs even better in future circumstances. But a main challenge in medical AI is that we still see many papers where it was maybe trained on only 1,000 or 10,000 examples. A lot of thought goes into our projects and how do we select questions that have a lot of data, and how do we actually curate the data in a large and meaningful way. We found that if we put a lot of effort in that, invariably it results in models that hopefully are more performant and generalize better.
Okay, so the answer is inputting mass data and getting a more clear outcome.
Yeah, I think for the liver, there's many different ways to look at the IVC in the liver, and there's many different pictures. But what we did is that we actually paired abdominal ultrasound results with the echocardiogram images. And then we found patients that had both abdominal and liver diagnostic tests with the echo images. And we used that as the training label. And then we used a wide arrayment of different types of liver images in the echo to train the model.
Okay, thank you. So finally, many of our viewers are early career cardiologists, and obviously because AI is really the hot topic right now, a lot of them may be eager to engage this AI research with their clinical practice in the clinic. So from your perspectives, what advice would you give them, whether in terms of developing the right skills, finding the good collaborations, or identifying meaningful clinical questions to pursue?
Yeah, lots of great questions. It's definitely an exciting time to be in the field. There's lots of great opportunities, and I think we're fortunate that it's a growing field where I think that there's a lot of opportunities to develop your own niche or kind of really push in a certain direction. I think in terms of training, I've been fortunate where I have a background both in cardiology as well as in computer science. I find both incredibly useful and necessary to excel in this area, right? The clinical questions we determine are really determined by my clinical background, but also you need to have that perspective of what's actually reasonable. I think that there's a lot of people who have a lot of expectation of AI and think it can cure everything and treat everything or do everything, but knowing what are the low-hanging fruit and what are potentially unrealistic clinical questions is really important to think about. One example, as Dr. Kang, you've already asked, is that we think of the scale of data as a particularly important thought or decision branch point, where we try to find tasks that have strong labels, that have a lot of labels, and that we have a lot of clinical data. Yeah, that's a much more performant way to train AI models than even if there's an incredibly relevant clinical question, but maybe experts don't agree, or you only have a case series of 100 or even tens of data. At the end of the day, I think it's an area that both requires computer scientists as well as cardiologists. So finding good collaborations is key, but it's an area that we think that many people can contribute.
Thank you so much, Dr. Ouyang, for joining us today. Your pioneering work in AI randomized trials and your perspective on echocardiography have been truly enlightening. It has been an honor to have you today on JACC Asia Pulse.
Yes, well, thank you for being with us today. And actually, for me, as a almost 100% clinician, it's a very new field. And as you said, your ComSci background, I think that it's doing a very large support for what you are researching right now. So thank you for being with us today, and well, have a good day. Thank you.
Yeah, Dr. Kang and Dr. Ahn, thank you so much for the opportunity to be here, and it was really fun to chat with you guys.